creatures that have fallen and have risen, that are low and exalted, comely and ill-favored, fortunate and unfortunate, and he does recognize that creatures follow the destiny of their deeds. In Christianity, whatsoever a man soweth, that shall he also reap. In Confucianism, good and evil do not wrongly befall men, but heaven sends down misery or happiness according to their conduct. The way of heaven is to bless the good and make the bad miserable. In Hinduism, as is a person's desire, so is his will, and as is his will, so is his deed. And whatever deeds he does, that will he reap. In Islam, every soul shall be recompensed for that which it has earned, and they shall not be wronged. In Jainism, every good will bear its fruit to men. Misery arises from wicked deeds. In this life and the next, people cannot escape the effects of their own actions. In Judaism, be sure your sin will find you out. In Sikhism, as a man soweth, so shall he reap. Human life is lost without virtue. In Taoism, the reward of good and evil follows as the shadow follows an object. In Shintoism, the souls of man vary in their fates. Good fate is brought about when man's sincerity is in concord with God's. Bad fate when dirt is accumulated in man's mind. In Zoroastrianism, at the beginning of life, the Lord of eternal light didst establish proper compensations for deeds and words, a bad compensation for the bad and a good compensation for the good. Okay. So yesterday we had discussed a number of things. We had ended with ileocecal valve, which we're going to workshop here in a few minutes. Remember that I had said that on every patient I check 3 things on every patient, every visit. Blood sugar, water metabolism, and ileocecal valve. Okay? Ileocecal valve, you'll find that, and when I say ileocecal valve, I'm also am talking about valves of Houston on the left-hand side, that when those 3 things are stable, the person generally does very, very well. And it took me a long time and a lot of patients to figure that out. Blood sugar, water metabolism, and ileocecal valve. By the way, Bruce, how's your occiput today? Good. And you didn't get it adjusted or anything? Or, yeah, just water. Yeah. Okay. Good. Now, with the ileocecal valve, just like with the TMJ, I highly recommend you check it in different positions. So don't just check it in supine, but check it right ear, left ear down, seated, standing, because it may not therapy localize just in the supine position. Okay, that's really important. All right, there are 2 basic kinds. There's an open ileocecal valve and a closed. We therapy localize right near McBurney's point. It's midpoint between the ASIS and the umbilicus. And if it therapy localizes, then we need to know whether it's open or closed. To close the ileocecal valve, we push in, pull up, and hold towards the left shoulder. To open the ileocecal valve, we push in and out towards the right hip or greater trochanter area. For the open ileocecal valve, the subluxations are C5 and L1. The neurolymphatics are on the right side, C2, C3 area lamina, bicipital tendon and below the ASIS. Acupuncture points are kidney 5 on the right, bladder 58 on the left. The nutrition is chlorophyll. For the spastic ileocecal valve, the subluxations are C3, L3. The neurolymphatics are for the quadriceps, the costochondral cartilage, T8, 9, and 10, lamina on the back, right and left. Bilateral bladder 58. The nutrition is calcium lactate. The muscle related to an open ileocecal valve is iliacus. There's a prone method of testing that. And the muscle related to the spastic or closed variety is the quadriceps. Now, an open you can think of as not enough tone, so they may need whole adrenal and to be acidified. The spastic would be too much tone. They may need choline and or to be alkalized. So you can kind of think of the ileocecal valve as a good indicator of too much or not enough. Okay. Any questions on ileocecal valves? I want you to check each other for that. Now, according to Scott Walker, the apes will cause a chronic ileocecal valve. That's allergies, parasites, and emotions. Allergies, in my opinion, primarily being food allergies, primarily. Wheat, corn, and dairy. Wheat goes with pec major sternal, dairy with psoas, and corn with supraspinatus. Parasites, just check for Zymex2, Artisan, Berber cap, citruside, and Entercap, strengthening a weak muscle. If so, give 3 times a day in between meals, or when you first wake up or just before sleep. That's another way to do it, just so they get it on an empty stomach. Emotions, just cross therapy localized to the emotional neurovasculars, and you can reset those. You can also become more specific and just ask, how are things at home? How are things at school? How are things at the office? How's the wife? How's the kids? How's the husband? How's the checkbook? That type of thing. You get a little more specific with that as well. Diet will also play a large role in the ileocecal valve, and do not eat things like, in general, popcorn, chips, nuts and seeds, spicy foods, alcohol, chocolate, or too much caffeine. Okay. Really a biggie. This is like, this and the next thing you're going to learn are huge in treating patients. And you'll get great results by just doing a few things. Don't neglect the emotional side. So anything I teach you, what could you do? Anything. Cross TL to the emotional. It takes but a second to put the patient's hand up there. Don't neglect that. That's the side of the triad, in my opinion, in general, most neglected by applied kinesiologists. In general, speaking in general, there are exceptions. Okay, so anything you can just cross TL. Okay, no questions on ileocecal valve? We're going to workshop it right after we do this next section. Oh, we got the wrong light on here. There we go. Okay. Yes, start with a strong indicator muscle. No, that's just the muscle that will be weak in association with an open ileocecal valve. And the quadriceps will be weak in association with a spastic ileocecal valve. But start with a strong, you're welcome, start with a strong indicator muscle. Okay, the next thing is almost as big or just as big. It can be larger depending upon the patient, but this is another thing that I would highly recommend you check every patient on. Not necessarily every visit, but definitely every new patient. These are the pectoralis minor muscles. The origin is off the coracoid. They go into the 3rd, 4th, and 5th ribs, and they bring the shoulder down and forward when they contract. The neurolymphatic is at just above the xiphoid on the lower portion of the gladiolus. Nutrition is RNA, so it's one of the 3 RNA muscles, middle belt, supraspinatus, pec minor. RNA, zinc, and vitamin A. RNA, zinc, and vitamin A. Here's an old test, which is old. This is a much better test. This was an improved test from Alan Beardall. And you bring the arm in extension, flexion, and across to the midline, and you're going to test up and out, up and out. And I'll show that in a minute. Okay, so that's the pec minor. The next thing we're going to talk about, here's another angle of that. So he's going to push sort of in an up and out position. The next thing we're going to talk about is a retrograde lymphatic technique. And during this whole discussion, realize that a retrograde lymphatic problem is mainly 2 things. It's a pec minor problem and dehydration. That's really what a retrograde is. It's really a pec minor problem and or dehydration. So keep that in mind. You should drink in general about a quart of water per 50 pounds of body weight per day, not with your meals, and I prefer distilled water. There's also a brand out now called Smart Water, and I have no financial connection with any water company. It's distilled water with the electrolytes added back in. And it's usually available at different health food stores. It's called Smart Water, and that's pretty good too. Okay. Retrograde lymphatic basically means that a patient will test strong in the clear, but when you retrograde the patient, in other words, the feet higher than the head, that they will weaken universally. We call that a retrograde lymphatic. And basically, all you do to correct it is correct the pec minor muscles. So if they're weak in the clear, fix why they're weak, and then check them for what? Strain, counter strain, fascial flush. Okay? Typically, you'll find one weak on one side, and then the other side will need fascial flush. It's kind of like the washer between the two rubber bands from session 1. It's kind of like that concept. Okay? So when you think of the washer with the rubber bands, you can think of it front to back of the body, like if the triceps were turned off, then the biceps will be hypertonic. But it can also be on sides of the body. Like if this SCM is turned off, then this one will be hypercontracted. So it can be front to back or left to right, right to left. So now we're adding to your skills and your knowledge. Now, let me just take someone up here and show you this, then we'll go through the slides. So we'll put the light back. And some of the indicators for this, I recommend you just check it on every new patient. But the patient will tell you this: Doc, I go to bed feeling pretty good and I wake up feeling pretty bad. Something to that effect. Doc, I go to bed feeling pretty good, but it's hard. When I wake up, I feel pretty bad. Okay, so things like flus, lymph node swelling, any type of extremity swelling, upper and or lower. Any type of immune system dysfunction. Realize that the lymphocytes are made in the lymphatic tissue, and neutrophils are made in the bone marrow. Remember that. Also, where does the thyroid release its hormone? Into the lymphatic system. The thyroid does not release it into the bloodstream. So we're going to have an entire discussion on the thyroid in session 5. So any type of swelling, immune system, also hyperlipoproteinemia, that type of thing. Okay, Jean-Paul Martinet, would you mind? Well, I think you might have this. This is very common in the French. Just teasing. Can we watch your knee? Just watch. Okay, now watch John Paul. Don't think about anything. Well, you change your knee. Yeah, there you go. This short stride is on the left, but when I asked him to walk, then he changed his stride a little bit, but it was real obvious before that. Lay on your back with your head up here. And now, the way to test the pec minor the old way is to bring the shoulder up and in and forward, and you would push down, out, and back. Okay, so wait, this one straight. And up, down, and forward. Okay, and typically it's very hard to find it weak when you're using that particular test. Beardall came up with a test where we had the arm in full extension, full external rotation, slight flexion, into the midline. I'm going to push up, out, and out in an arc. And see the difference there. That's where you're going to find it. You're trying, right? And bring this one here. Now on Jean-Paul, we have bilateral weak ones. Okay. Now, any questions on that? How to test the pec minor? Okay, so you're going to do it in just a few minutes. Now, if we take a strong indicator muscle, elbow straight, push back hard. Push back hard. Okay. And now I don't have a table that will elevate. We can turn the patient around if he had a high-low. So what we're going to do is feet and knees together, bring the hips up, keep them up. We're going to let the lymph drain down. That's what we're doing. So we're letting the lymph drain down by retrograding the patient. Okay, keep your hips up. And we'll just simply test our strong indicator muscles. That one's okay. This one here. But not that one. Oh. Okay, that's a positive. That's a positive retrograde. Okay, so we're just simply retrograding the patient and checking for strong muscles weakening. In reality, it's really you just fix the pec minors. As you know, the thoracic duct drains the entire body except the right side of the heart, the right side of the head, the right lung, and the right upper extremity. That's the right lymphatic duct. But the entire rest of the body is through the thoracic duct. Okay. Now, so how could we fix the pec minor? We'll just start with origin insertion. We'll go to the coracoid process. Says it's not that. We'll go to the third, fourth, and fifth rib. Bingo. Let's go one at a time. We'll go to the third. All your fingers together. Definitely the third, not the fourth, and not the fifth. So we just have to do the third. Okay? Now, tender here. Now, so I like Jean-Paul, so what I'm going to do is in what position? In the fold and hold, not as tender that way. And if the patient says that hurts, just put them in the fascial flush position and then show them how much more it hurts. Okay. Now, let's recheck it. Don't hold your breath. Okay, that's good. Now we check it for 51%er, so we re-therapy localized, same spot. Sorry, Jean-Paul says I didn't do it enough. It's a French thing. See, it's okay to make ethnic jokes when that's part of your heritage. So if you're French, you can make French jokes. If you're Irish, you can make Irish jokes. Okay. Is that the same stuff? There we go. That's good enough. Okay? So now I'm going to fix this side. Okay? So we'll go to the coracoid process. Go ahead. Okay. So we'll go to the third rib. Yep, he's got a third rib. Fourth rib. Oh. Fifth rib. No. So it's just the third also on this side. So I'm going to do the origin insertion, but in the fold and hold position for him. That's a good one. This is typical of a white wine deficiency. Joking, of course. I think more Cortone Charlemagne. Yeah, definitely. The reason I also bring that up is what things dehydrate you? Sugar, caffeine, chocolate, alcohol. Those are all dehydrators to the body. And the French don't drink wine, you know that. So now we check it for 51%er. No, that's pretty good. Okay, so let's put them in the retrograde position again. Feet and knees together. Now what I didn't check the biochemical. That would be RNA, vitamin A, zinc, and I didn't check the emotions. Okay, so when I'm demonstrating things up here, realize that's not necessarily how I would treat the patient in my office, but I'm demonstrating a procedure for you. Okay, but try to keep in mind the three sides of the triad of health: structural, chemical, and emotional. Keep your hips up. Okay, keep your hips up. Okay, no, let it down for a second. Keep your hips up. Keep your hips up. I know this wasn't weak to begin with, but just want to make sure. First, do no harm. Push. There we go. Okay, that'll help you. Okay, any questions about retrograde or pec minor? I would also question, Jeff, just out of curiosity, do you drink about a quart of water per 50 pounds of body weight per day? And you do, okay. You might want to get the type of water tested. The other thing about water is it should be at what pH? 7. It should be a neutral pH of 7. So what you can do is just take some litmus paper, like what we do for oral pH, which we'll talk about more at session 7 when we discuss fats. It's just simply measure the pH of your drinking water. Make sure that it's not like a 5 or a 6 or a 5.5. You want it more towards the neutral pH. And don't drink things like, Pellegrino or that other water from Sweden where it's like salt water. Okay. So, yeah, Pellegrino is almost seawater, which is good if you're very hypoadrenic because you need the sodium, but other than that. What if the patient says, Doc, I drink so much water that I think I'm going to float away, and yet they're dehydrated? Check adrenals because they're probably not producing enough of aldosterone to regulate electrolyte balance in the body. Remember we talked about the Königsberg's test, which should titrate out to 17 to 25. Greater than 25 drops means they need sodium. Things like zucchini, celery are naturally high in sodium. Okay? That's a biggie. Retrograde is huge. So right after, maybe not even right after, just put ileocecal valve dash retrograde, just because they're both equally important. I mean, they're very, very important. Now, since we're talking about limb swelling, let's just talk about it briefly. What if you have a non-pitting edema of the extremities, a non-pitting edema? It's usually adrenal glands, and the patient usually requires sodium. Simply do the urinary Königsberg's test. Okay, a non-pitting edema. Now, what if you have a pitting edema? That's right, either nephrotic syndrome and or congestive heart failure. Okay? All right. Okay, so now let's go through the slides and then we're going to workshop. And then we actually, after the workshop, we will have officially completed all of the course material and actually then some for session 3. We'll have a lot of free time left over. So what I would like to do is teach you 2 teach you one very important new thing that's not part of the course called the deep tendon reflex technique from Richard Belli in Sacramento, and then start teaching about the TMJ a little bit early. Usually I like to start the TMJ early so that by the time we get to session 6, you already know about 80% of it. And it's more of a review and there's a little addition. That's how important the TMJ is. So anyway, let's go ahead and do that. And the lymphatic system is the garbage disposal system of the body. And the thing that moves the lymph is what? Muscular contraction. So people who have retrograde lymphatic, they say, I go to bed feeling pretty good, but I wake up feeling pretty bad. Because your lymph doesn't move as much at night when you're laying down. They actually feel worse from rest. What about a foot patient? They're going to say just the opposite, aren't they? They're going to say, Doc, I wake up feeling pretty good, but as the day goes on, I feel worse. That's your foot subluxation patient. Or tight shoes. Okay, so the right lymphatic duct drains the right side of the heart, the right side of the head, the right lung, and the right upper extremity. The thoracic duct drains the rest of the body. Body language, any type of edema, node swelling, joint pain, tissue tenderness, any type of lymphatic conditions, hyperlipoproteinemias, digestion, thyroid. I would check it on every new patient. It's just that important. So you take a strong muscle, retrograde, and they weaken. You don't need the table. You can just do what I did. Use the feet, raise the pelvis up. Remember, muscles act as pumps for organs and tissues. And if they have a tight one on one side, the shoulder will be rolled down and forward. What would cause that? A weak lower trapezius. And sometimes with a tight one, now on John Paul we had 2 weak ones, but on a tight one you check it for strain, counter strain, and fascial flush. Okay, let's just do a quick review, and let's just finish up the slides. A ligament stretch, realize you can have it globally all over the body, or you may just have it over one joint, like a trick knee, for example. So you take a strong indicator muscle, just stretch the ligaments, and then that muscle crossing that particular joint will weaken. A subluxation, you have to be very specific and challenge it in one direction. A muscle stretch would stretch a muscle in it weakening after a gentle stretch, and it should strengthen via the myotactic reflex with a gentle stretch. What's the nutrition for a positive ligament stretch reaction? Whole adrenal, sometimes 1 an hour. What's the contraindication for whole adrenal? Possibly hypertension. Okay. And a muscle stretch reaction, what's the nutrition for that? B12. You guys should know that by now. Okay. So a normal articulation can accept transient forces with no muscle testing change. Now, in this extraspinal, there is no rebound phenomenon because there are no intrinsic muscles. So let's say in this particular slide that you have a proximal medial tibia and is creating a weak quadriceps. You want to know how to correct it, so you challenge it from medial to lateral, and it turns on the weak quadriceps. So you go in the challenge direction. However, if you're starting with a strong quadriceps and you challenge it medially into lesion, and it weakens the strong quadriceps, then you go opposite the challenge. So in the extremities, it depends on whether you're starting with a weak or a strong muscle. There is no rebound phenomenon in the extremities because there are no intrinsic muscles. And if you're starting with a weak muscle and it strengthens it, you go in the challenge direction. If you're starting with a strong muscle in the extremities and it weakens it, you go opposite the challenge direction. Okay? A muscle stretch reaction, this is just a review. You've known this since session 1. There are only 2 types of trigger points. What are they? Fascial flush and strain, counter-strain. You've only got 2 choices. A trigger point, according to Travell, who used to be the physician to President Kennedy, quote, a small hypersensitive region from which impulses bombard the central nervous system and give rise to referred pain. Her definition, pain radiation from digital pressure, jump sign, a shortened muscle because its antagonist is weak, and a positive muscle stretch reaction, meaning that a strong muscle in the clear will weaken after a gentle stretch. So we usually use fascial release. You can also use stretch and spray, but I don't like putting chemical toxins on patients' skin, so I don't do that often. So you massage towards the heart in the direction of the muscle fibers. Okay, strain, counter-strain. This was discovered by Dr. Lawrence Jones. His definition of strain is overstretching of muscles, tendons, ligaments, and fascia with the intended neuromuscular strain reflexes. The focus of attention is directed especially at the neuromuscular reflexes rather than the tissue stresses. His definition of strain. Counter-strain, according to Jones, is a mild strain applied in a direction opposite that false and continuing message of strain from which the body is suffering. Strain, counter-strain. Core, his definition, the primary muscle is stretched and strained. We have strong neuromuscular spindle 1A impulses for adaptation. The antagonist muscle is shortened where the neuromuscular spindles are silent. The central nervous system has a strong outflow for adaptation, so we get a high gamma gain not reduced to normal. If you've ever read Core's book. So where it is, it ain't. What it means is sometimes where the patient's symptom is, that strain counter-strain will be found opposite where the symptom is. Kinesiologically, we see that a strong muscle weakens after a 3-second maximum contraction. So strain, counter-strain, you palpate the trigger point, doctor is active, patient is passive. If it's on the front of the body, it's usually flexion. If it's on the back of the body, it's extension, except for 2 exceptions. What are they? Piriformis and neck extensors. Those are both done in flexion. If it's on the front of the body, the patient holds their breath in. How long should you be able to hold your breath? 40 seconds. If not, check D vitamins and or diaphragm. And on the back, the patient holds their breath out. It says here a spread point apart. What Dr. Goodhart does is he'll be on the trigger point, and you'll fold and hold, and then fine-tune to find the area, the exact position that decreases it the most. Then he'll just spread his fingertips apart while he holds that position. According to Dr. Leaf, that isn't necessary. Just the fold and hold with the breathing is enough. Either way, you can do it either way. And then the really important part is slowly you return that joint back to neutral so as not to recreate the strain, counter-strain. Okay? So this you should know real well by now. This is all from session 1. Okay, so here he's having her contract the psoas, which tested strong in the clear. And it weakened it, so now he's palpating for the trigger point in the psoas. She relaxes, and he finds and brings her up into flexion that reduces the point the most, either down to a 0 or a 1. It's on the front of the body, so she's going to hold her breath in as he holds that position. And then after he's done, he'll slowly return it to neutral. What's the main nutrition? Folic acid, also glycine, and the nutrient associated with the muscle on a muscle organ basis. Okay, oh, I forgot about this. We have the TS line to cover yet. So let's hold off on the TS line, and we'll talk about that after the workshop. So here's what I'd like you to do on this particular workshop. I'd like you to check each other for ileocecal valve and retrograde, and fix what you find. Let me have there's been a couple of complaints that the teaching assistants aren't quite organized, so let me take care of that problem right now. All the TAs stand up. Okay, so Julie, Tui, you take the first row. Rob and Keith, the second and third rows. Just come right here in the middle. Come right here in the middle, Keith. Let me get Ryan to take the fourth row. Where's Gary? Gary's still at his formal party. Okay, the fourth row, so come up one. And let me get Jeff and Carla to work together on the fifth and sixth rows. John Paul will take the seventh. John will take the eighth row. And come right over, John Paul. And where is Derek? Okay, Derek is MIA, and so is Gary Fawn. Okay, so when they show up today, we're all going to give them a big good morning, okay? Good morning. So you guys each have your rows, and let's do that right now. Let's take about 25 minutes. This is a really important workshop. I want you to check each other for ileocecal valve and retrograde. We wrap it up, finish up what you're doing, take your seats. Were there any questions from the workshop? Ileocecal valve, valve of Houston, retrograde, pec minor. Yes, you can have both an ileocecal valve and a valve of Houston. Yeah. Now, yeah. No. If you find a valve of Houston, then all the points for the open will be on the left. For the closed, it doesn't matter because they're bilateral. But if it's an open, yeah, you need to do the C2, C3 lamina on the left, bicipital tendon on the left, below the ASIS on the left, kidney 5 left, bladder 58 right, C5L1, same nutrition. Let me ask you a question. If a patient complains of diarrhea, would they have more an open or a spastic ICV? Open. If they complain of constipation, would they have more an open or a spastic? Spastic ICV. Okay, very good. Yes? Yes? Okay. Any other questions? Retrograde, ileocecal valve? Okay, our next and last topic, officially for session 3, is the TS line. That's in the beginning of your workbook. So turn towards the beginning. And if we could get the projector on, it might be easier to visualize. Yeah, sure. History of chronic constipation. Heavy users of laxatives. Will they tend to change with good treatment? Yes. To what? A laxative can, depending upon the laxative, can cause many things. Now, if you need to use a laxative, we're going to have a whole talk on the digestive system in session 8, the down the tubes lecture. But okay, constipation, look. Dehydration, lack of fiber, too much sugar, lack of exercise, low thyroid. Real basic. Constipation is not that hard to fix if the patient is willing to change their lifestyle. Pretty easy, actually. What about diarrhea? There are many causes of diarrhea. We're going to have a whole talk on that at session 8. But diarrhea, you want to think of an open ileocecal valve. The patient is probably toxic and or check for parasites. Thymex sometimes can be very helpful in diarrhea, and Zymex wafers. But don't try to stop it. Just make sure you get plenty of fluids and potassium, like bananas and oranges. Okay, anything else on ileocecal valve? That's a biggie. Retrograde's a biggie. Now, let's turn our attention to the TS line, which stands for temporal sphenoidal line. This was discovered and developed by M.L. Reeves of Sedan, Kansas. R-E-E-S, M.L. Reeves of Sedan, Kansas. And these points represent trigger points within the temporalis muscle. And starting from the anterior portion of the external auditory meatus, we have the psoas, quads, sartorius gracilis, pec major sternal. So these are the ones horizontally. Then we start vertically. Hamstrings, quadratus lumborum, glute max, TFL, and the piriformis adductors here, glute medius. Then going back, we have the sinuses, subscapularis, serratus anterior, deltoid coracobrachialis, and popliteus, pec major clavicular, diaphragm, latissimus dorsi, abdominals, and middle trap. So that's all in your workbook. We used to give out like a business card with this on it, and you could place it on the patient's body or forehead as they were laying supine, and as you palpated, you would have that reference. So what you could do is just take this on a photocopy machine and reduce it down as you're practicing this. This takes quite a bit of practice. It's kind of like learning to palpate all over again. And they feel like possibly little BBs under a raw slice of bacon. They're very subtle, and there are also vertebral levels associated with these, which are in your workbook, T12, 11, 10, 9, 8, and going up L1, 2, 3, 4, 5, skipping, and then T2, T3, T4, T5, skip T6, and T7. It's all in your workbook. So there are muscles, there are organs, and there are vertebral levels associated with this. What this will do, this is one of the 3 primary diagnostic modes in applied kinesiology along with traditional diagnostic procedures, and they are postural analysis, TS line, and then pulse point diagnosis, which you'll learn in session 5. But the TS line is part of the 3 primary diagnostic modes. And this was also utilized in sacro-occipital technique developed by Desjardins. Their TS line is a little bit different, but basically the same. Theirs comes around here and then comes sort of down this way. Okay, so theirs a little bit different. Ours follows the sutures. And I can just take somebody and demonstrate. Rudy, you look like you need help this morning. Come on up here. And lay on your back with your head up here. When you're doing this, I would highly recommend that you do this with the patient supine. So we'll just start anterior here. And right away I pick up a big psoas here and also a secondary psoas on the right. So right away we pick up psoas and psoas. That's just from the TS line. The TS line never lies. Push up. That's weak, and he's really trying. Bring this one up here. Push up. Now, what are the vertebral levels for the psoas? T12 and T11. Lay face down. bring this up here, push back. Now, TL, T12, T11 area, you can do palms up if you want, that's easier. Right about there. Push back, and they do TL. Okay, so we have subluxations around that area as well. That's also, don't forget where the psoas originates from, doesn't it? T12 anyway, T12 disc, L1 and on down. Now, turn over on your back. There's also a respiratory component to the TS line, and the TS line points will therapy localize. Bring this up here, push up. Now, give me one finger. We'll go right to the TS line point here. Push up. And that does therapy localize. There's a respiratory component. Breathe in and hold it. What does that mean? It means there's a cranial associated with it. And if there's a cranial, what is it? No. Are you back right on where you were? Okay, kids. All right. Up there. All right. Now, push. Now, if there's a cranial associated with it, there's also TMJ. Open your mouth wide and hold it open. Okay? So really, what are these things? My opinion, I agree with David Lee, is there nothing more than trigger points in the temporalis muscle. And if there are trigger points in the temporalis muscle, it means there's dural torque, and if there's dural torque, there's a TMJ, and if there's a TMJ, there's an atlas. Anyway, let that go. Bring the arm out. Open. Okay. Well, we can continue up here. Atlas is caused by food allergies. He's got a quad on the left, push. Come on. Okay, he's trying. Oh my goodness. He's got a sartorius or gracilis on the left. Drop it. Don't hold your breath. You see it? Pull up. I know he's going to have liver. Oh my God. Tender.
Or pumpkin pie.
Sure. Okay. So, in other words, you can see what I'm doing. It's just simply where's the slide? Thanks, Jen. Just all I did was just palpate this far. See how much information I already picked up? Now, what I'll do during the workshop is I'll leave this up here, but I'd like you to have your patient supine, is the best way, and then just take that out of your workbook. You can put this right on their chest so you have a reference, and then you can just palpate, okay? And then our TAs will come around and hopefully will help you to locate those. If you're going to learn the TS line, which you need to learn, definitely if you're going for the diplomate, you need to do it every day on every patient. And it's just going to require a lot of work. Once you get it, it's kind of like getting that anterior cervical. Once you get it, you got it. But it's going to require constant practice. It's like learning to play the piano, you know, with the white and black keys reversed. I mean, it's just going to take a lot of practice. Now, there is a respiratory component, which means there's a cranial component. If there's a cranial component, there's a TMJ. If there's a TMJ, there's an atlas. Okay. Okay, sir, you need it. Down. Elbow straight. Turn the light off, please. Push back hard. Bring this up here. Push up. Push up. Push up. Drop it. Pull up. Okay. So when you know how to adjust properly, you can get a big bingo. Why do you think I teach you in a certain order? There's a reason for that. I'm going to shortcut it for you and teach you how to really fix people in the shortest amount of time. It's nice to know some of these other things. But when you know the directions to the internet, you can get to the source, can't you? And I don't, okay, on the internet. I know the body. You get me on the computer, we're in real trouble. Okay? But the human computer I'm pretty good at. So let me show you how to do that. But this is something you need to know for the diplomate if you ever desire to do the diplomate, and it's a worthy cause. And if there's any way I can help you to do that, I'll help you to do that. So you do need to know the TS line for the test, not for the practical, but for the written. And it is something that is there. It does not lie, but it doesn't necessarily tell you how to fix it, but it tells you that it's there. You can pick up a lot of information within just a few seconds when you get real good at it. Definitely recommend you do it with the patient supine. There's a respiratory component, which means there's a cranial component, which means there's a TMJ component, which means there's an atlas. Every time you have a TMJ, you have an atlas. Every time you have an atlas, you have a TMJ. Okay? Yeah? Say it again.
You mentioned that the liver would be tender.
I pick it up off the TS line. He had, turn the light on. He had that point bilaterally, which is the pec major sternal liver point. So I knew he'd have a liver involvement. Okay? Get checked for wheat, dairy, and corn. You already know it, but you're not practicing it. Not this weekend, I know. I saw those eyes at 9 o'clock, or 9:30 this morning. Okay. So, yeah, but that's what's causing that to really torque out like that. C1. No, I didn't say all the points came normal, but the points became normal of the ones that I checked anyway. Yeah, what I showed is that for each TS point, there's a weak muscle if it's active, that there's a vertebral level for each point, that the TS line point, if active, will therapy localize and be negated by either a breath held in or a breath held out, which means there's a cranial component. I also demonstrated that if there's a cranial component, there's a TMJ component. I also demonstrated that if there's a TMJ component, there's an atlas component. No, I didn't say just adjust the atlas. I simply demonstrated the connection between all of them. Yes, it did on Rudy at this time by me adjusting it. For me, yeah. For Rudy at this time. Okay. So, anyway, here's what I'd like you to do. We're going to leave that up there. You have it in your workbook. I would take the piece of paper, have your patient supine on the table, put that on the chest so you can have that as a reference right there. And the way that I learned this, and I did this for many, many years, but the way that I did this is, wait a minute, is what I would do is have the patient, where'd you guys go? I would have the patient therapy localized around the TSN. So I would start here, then I would go here, and then I would go right back around the TS line, and then I would go point by point till I found the one that therapy localized. Then I would go and palpate it and went, oh, that's what an active TS line pulse point feels like. So that's just the way that I learned it. First I memorized it so I would know, so quads, bridges, PMS, hamstring, cortisol, glute maxi. I mean, I memorized it. But the way that I learned how to feel it is I would have the patient therapy localize the different sections and then go one point at a time to find the active point. Then I would palpate that point. And that's how I learned how to feel what they feel like. That's just the way that I learned it. Whatever works for you. But if you're going to learn it, you need to practice it every day. It's a palpatory skill, and it's like learning to palpate all over again. But they kind of feel like a little BB under a raw slice of bacon. It's kind of what an active TS line point feels like. This was developed by M.L. Rees of Sedan, Kansas. And I've said that about 3 or 4 times, so you think it might be on your test. And it's also utilized in SOT, which was developed by Desjardins. Okay? Alan, you had your hand up? Okay, so this is our last official workshop for session 3, official material. And so why don't we take, about another 20 minutes and just palpate each other's TS lines and call a TA over if you're having a problem to feel that. Okay, so we'll start again at 11:15. Take your seats.
Take your pick.
Possibly need to do fascial blood. Do that.
Would anyone like a standard process back it up? Test something?
Yeah, I got like 100 of them.
Okay, let's wrap up what we're doing. And Bruce, how's that editing going? How did that workshop go for everybody? Did you get that TS line down? It takes a little time, at least it is for me. Were there any questions about the TS line? Okay. A TS line point is a trigger point in the temporalis. You can have active spindle cells, but no, that won't cover it up. So if you have a TS line point, don't forget, remember, where does the dura attach? Firmly to the sutures via the cerebrum, the falx, and the meninges down through the spine, but it's firmly attached to the sutures, occiput C1, 2, and 3, the sacrum, and through the filum terminal into the coccyx. So also we want to check the lower. Now if Rudy had a C1, what would be the Lovett brother to C1? L5, that's really important. Lay face down. And bring this foot up here. Push back. Okay. TL L5. Push back. Okay, so we definitely have a subluxation at L5. Did that tell me how to adjust it? No. So we use the challenge now. And I think it's anterior, but we're going to find out I'm just going to hold it anterior. Push. Okay. And it's anterior, so turn over on your back. We can use that maneuver I showed you yesterday for a lumbar fix, or also works for anteriorities. Rudy, put your hands like this behind your head, let that go, and there you go. I'm going to do a slow, gentle stretch each way. Just relax and let me do all the pulling. I'm going to put this arm through here with the back of the hand on his body, let all the air out. There it was. And keep your hands there. And just relax here. Get arm right through here and let all the air out. There it was. Okay? And that's it. Okay? So anytime you have a C1, check the L5 or T5, T6, T4, T7, C5, L1, C3, L3. But from C3 to L3 and up, they move the same. From C4 to L2 and together, they move opposite in general. Okay? So you can't recognize what you don't know. You don't know what you don't know until you know what you didn't know, and then you might know. The more you know, the more successful you become. The more successful you become, the more you need to know. The more you need to know, the more knowledge you get. The more knowledge you get, the more you know. The more you know, the more successful you become. Now, any questions over what we've covered so far? You feel real good about ocular lock, lateral occiput, primary atlas technique, the upper half to gate, the lower half to gate called piriformis gait inhibition, bending and extending, which is the plus mechanism, both standing and seated, hidden cervical disc, weak wrist extensors, possibly triceps, palpable calf pain, it's an anterior cervical, superoxide dismutase nutrition, limbic fixed, the deer comes to the edge of the forest, he sniffs to the right, he sniffs to the left. It's a fixation between C7 and first rib. Or the lower one is L1, T12 rib head. All the ankle muscles will be weak on one side. Ileocecal valve, retrograde, because if you're not, I'm not going to teach you the next thing. Yeah. I would use ocular lock. Yeah, if you're asking me, I would use ocular lock. Okay. Anything else? I know you don't know the hyoid yet, but the hyoid is a little mandible under the mandible that's suspended by 16 different muscles, and we'll learn about that at session 6, but just make a note after ocular lock. Okay? All right, what I'd like to show you now is something called the deep tendon reflex technique. This is based on the work of Richard Belli out of Sacramento. And basically, if we elicit a deep tendon reflex, for example, the patellar reflex, the ipsi hamstring should shut off once. The opposite quad once. This is not written in your workbook. And if we check the upper extremity deep tendon reflex and we elicit a bicep reflex, the ipsi tricep should shut off once. The opposite tricep once. Now, no way. Okay, think about it. If you elicit the patellar reflex here, what should happen to the hamstring? Should shut off, but only once. And the opposite quad once. If you're doing the upper, if you elicit a bicep reflex, ipsi tricep should shut off once, opposite bicep once. Good morning, Dr. Fong.
Good morning, Dr. Fong.
Okay, yes, it is. Okay. And Derek has failed to join us yet, so yeah. Okay. to show you is that even if they pass all of those things, they may not necessarily pass this. It's like a whole separate issue. Okay? So that is an excellent flow chart to follow. But add this to it because even if they pass all of that, they may not pass this. It's like a whole entirely separate thing going on in the body. Okay? So, let me get somebody up here. Bruce, come on up. Have you been drinking your water? Okay. Were you a good boy last night?
Yeah, that's
Now, if you recall, Bruce yesterday had weakness of bilateral upper tract SCM, and what we found was that he was just dehydrated, so we had him drink more water, and when we rechecked him, they turned back on again, and then the gait and the plus and everything was working well yesterday after that. So let's just see if that's still the case. I just brought these in to make it a little more festive in here for you. Now look straight ahead. Bring your ear and shoulder together. Hold it if you can, and that's real good. Bring the head down and to the left. Hold if you can, and that's real good. Yeah, scoot a little bit to your right. And bring your ear and shoulder together. Hold real hard. Wait. Okay. Hold. Okay. Bring your head down and to the right and hold real. Okay. So look straight ahead and step forward with the right foot. That's good. And that's good. Step back even. And look straight ahead, other foot. Bring your ear and shoulder together. Hold real hard. Bring your head down and to the left. And that's good. Look straight ahead. Bend forward. What should happen? Okay, that's good. Have a seat right there. Also check it's seated. Scoot towards me, palms up on your thighs. Bring your ear and shoulder together. Okay, bend forward 30 degrees. And that's good. Bring arch back 30 or 15. And that's good. Okay, so the walking gait is good. The plus is good both standing and seated. And let's have you lean up against here. We could have maybe Rob hold that other side there. Bring this knee up. I'm going to push out, Bruce. You push in. Bring your left arm up a little bit like you did. Other arm back. That's good. Bring this one up. I'm going to push out. You push in. Bring that arm up, that arm back. And that's good. So his piriformis gait is good. Walking gait is good. Plus is good. Right? Okay, lay your back up here. Eyes up to the right, down to the left, down to the right, up to the left, straight down, straight up, straight right, straight left. That's pretty good. Make a fist, bring your wrist in. Good. Elbow straight, hand back. Good. Make a fist, bring your wrist in. Good. Elbow straight. Good. So that's good. Primary atlas, hidden cervical disc. Push up. Push, push. Okay. Go to ICB. Push. Valves of Houston. Other way. Okay, so at least in the supine is good, right? Elbow straight here. Push back. Elbow straight here. Push back. Okay. Lift your hips up. Keep them up. What are we checking them for? Retrograde. Keep them up. Elbow straight. Push. Anything that falls on the floor is mine. Push. Okay. So it doesn't have that. All right? You agree? Pretty good. Okay, let that go. Turn over, leg face down. Bring this foot up here. Push back. Touch here and here. Bring this up. Push back. Push back. Turn your head to the right. Turn your head to the left. Doesn't have that. Touch here and here. Bring this up. Lower limbic fix. Push. Turn your head to the right. Left. Doesn't have that. Right? It's pretty good. So he probably doesn't have the other fixations, right? Probably. We could check them, but raise that straight up. Is that it? Put your head down, Bruce. Don't extend. There you go. Push up hard. There you go. And here, raise it up. Push up hard. Now, I'm going to artificially create an upper cervical fix. Bring your head back in extension this way and hold it back tight. Raise it up. Push up. See, that's what should happen when you tighten up the suboccipital area. You're artificially creating an upper cervical fix. Anyway, he doesn't have that. He doesn't have any of that, right? Laying your back. Okay, hands up here, elbow straight. Push. Stick your tongue straight out and to the right, out and to the left. He doesn't have that, right? Okay. Does that all of that except for maybe the hyoid? Take a strong indicator. Any reason doesn't show on right to left, left to right, okay? So he doesn't have that. Now, we're going to do a supine hamstrings, toes up, pull your heel back. That's good. That's how you do a supine hamstring. Bend your knee, toes up, pull your heel back to here, and that's good. We've already checked this quad. Let's check the other quad. Push up. Okay, now, when I elicit this DTR patellar here, what should happen to his hamstring on this side? Should shut off once. This is my fancy gold-plated reflex hammer. Okay. Pull your heel back. Pull your heel back. Isn't that what it should do? Based on what I taught you anyway? Yeah. Bend here, toes up, pull your heel back. Isn't that what it should do? Yeah. Now, up here, if we test, I know you don't know the triceps yet, so I'm mainly going to have you do the lower extremity today. But to test the long head of the triceps, thumb is up toward the head. Bruce, I'm going to push up, you push down. Okay? And I'm going to test the long head of the biceps, I'm going to push down. Okay? Now, when I hit this bicep reflex, the ipsy tricep should shut off once. Okay. Push. Isn't that good? I'm going to test the tricep here, push down. Push up. Let this relax here. Push down. So that's pretty good, isn't it? Yeah, that's a normal response. Okay, you're all set. You were just dehydrated. Now don't let anyone touch it. Leave it alone. Rob, come on up here. Lean your back with your head up here. Okay, we're going to test the supine hamstring, so toes are up. Why? So we don't recruit the gastrocs. Okay, so I ask the patient to bring the heel there. I'm going to pull this way. I'm going to stabilize here. Okay. Toes up. Okay, now put that there. Bring this up here. Push up. Push up. Okay, so you have to start with those flexors and extensors strong. What should happen when I elicit this deep tendon reflex here? Ipsy hamstring should shut off once, opposite quad once. And pull back. Pull back. Pull back. Pull back. pull back, pumping for Earl, pull back. I don't think we've hit it yet. Is that a normal response?
No.
No. Here's where you look first. Scoot back up, Rob. And he's holding his breath and trying to recruit and do all that. Look to L3. If it's not L3, L4. If not L4, L2. But start at L3. TL L3, but don't let your hands touch each other. Got it? Bend. Hold your toes up. Bingo! Does that tell me how to correct L3? No. Lay face down. Now, well, why don't you just have them TL it? Just start at L5 and just TL and just fix what you find. Oftentimes it doesn't show that way. Bring this up and push back. TL, L5. Push back, L4. Push back, L3. See, it doesn't show. Now, we can challenge it. Goes harder left to right, easy right to left. I'm going to do a spinous from left to right. Push. Yeah, it's like a PLS. Okay? So, is it okay, right? Lay on your right side facing this way. Now, this table's a little high for me, but I'm going to use a long lever because it also palpated a little bit anterior. When you want to correct an anteriority, always take it with flexion. Posteriority is with extension. There it was. Laying your back. Okay. Pull back. Bingo. Pull back. Bingo. Okay? But it doesn't mean it fixed the upper one. Or it doesn't mean he had an upper one. You've just got to check them both. Push down. This up. Push up. Let this relax. Push down. That's good though. That was good. Push down. Push up. Let this relax. Push down. So the upper is okay on him. Okay? If you do find an upper, check C3. If it's not C3, C2. If not C2, C4. That was worth the whole weekend, just that alone. That's huge. That will fix all allergies pretty much, except a true wheat, true dairy, or true corn. Non-solicited.
Last year I had a patient come in who had rashes all the way down his legs and his low back. He's been going to a dermatologist over a year, and he spent over $800 on creams from the dermatologist for the rash, which hasn't been going away. And he came in to see me and was doing a physical on him, and I said, "You might be able to get rid of your rashes, I think, or an allergy." He says, "Oh, okay, whatever, I'm just here for my ankle pain." So after 2 treatments, his L3 was out, I fixed his L3, after 2 treatments, comes in furiously mad saying, I can't believe this. I spent over $800 in these creams, been doing it for a year, nothing happens. I come to you twice for a fraction of the price, and my rashes are completely almost gone after 2 weeks. And he just came in for ankle pain. He didn't expect that.
Okay, any questions on deep tendon reflex? That's based on the work of Richard Belli in Sacramento. No relation to Melvin. I know it's a little early. Keep the day job, I know. I plan on it. Okay, any questions on deep tendon reflexes? So where would you put that in there? Wherever you want, actually. That deep tendon reflex is huge. I definitely would do the ocular lock and the hyoid occiput and atlas first, but you could even put that before gait if you wanted to, really. It just, wherever you want to fit it in there. Okay, it's that important. It fixes what is an allergy, first of all? We're going to have a whole talk on allergies at session 7. However, most people who suffer from airborne allergies, typical hay fever, will have stomach dysfunction and adrenal dysfunction. So you fix the stomach and the adrenals, and their airborne allergies either greatly reduce or go away completely. So this is another way of, I think, just fixing the body. I think this is, Bruce, I usually get a bigger tip than that, but you just simply fix the body. Don't fix the allergy, fix the body. See, allergies usually pollens don't cause allergies, they aggravate them. Alan?
What's the difference between a true wheat, dairy, corn allergy and a not true?
That's a good question. What's the difference between a true wheat, dairy, corn, or not true? True one you can't fix. They just don't have the enzymes from their mother's and or father's side of the family, either to break down gluten in the wheat or casein and or lactose in corn, in dairy, and I'm not sure what it is in corn. But you know what? If a pec major sternal weakens to wheat, I tell them that just to stay off it. They're going to be off wheat anyway. Why? Because pancakes and no, not carbohydrates, but pancakes, sugar, pancakes and French toast and waffle and bread and pasta. Those are all sugars anyway. You're going to take them off. If a psoas weakens to dairy, I just tell them to stay away from dairy. Dairy causes osteoporosis. Milk, cheese, cottage cheese, yogurt, sour cream, cream, and ice cream. Butter is okay, and eggs are okay. And if a supraspinatus weakens to corn, I just tell them to stay off corn, popcorn, corn chips, corn on the cob, cream corn, corn bread, high fructose corn syrup solids, corn starch, and corn syrup sweeteners. Yeah. Doesn't. Say again? Nope. He wants you to focus on the TMJ. Okay? Any questions on deep tendon reflexes? Pretty good about it. It's pretty simple. Just check the quad, the hams. Elicit the patellar reflex. The ipsi hamstring should shut off once, opposite quad once. If not, have the patient therapy localize L3. If that doesn't correct it, then try, L4, L2. Okay, but start from there and work up or down. Same with the upper. Check the tricep, the long head of the bicep, elicit the bicep. The ipsi tricep should shut off once, opposite bicep once. If not, check C3 and then work up and down from there, C2, C4. Usually it's where the dura attaches, so, or it's loving. Okay? Yeah, try that. I think, I didn't know Rob was going to even tell you about his experience with this, but anyway, it's that powerful. It's really, really a winner. So, it's a good one.
you had, Bill, we put his hand on his upper
Bruce.
roof. I still had it, right? What was that for?
Limbic fixation. That we learned yesterday, you have a handout on that. Okay, let me start you on a journey called the TMJ. And we'll just start it today. And I think then we'll finish up. We've already covered a lot more material than normally you would by session 3 anyway. Okay? I mean, would it ruin anyone's year if I started the TMJ today or? Okay. Now, according to Penfeld and Rasmussen, 35 to 40% of all the motor and sensory nerves of the body are related to the TMJ, making it an extremely important joint in the body. Every time you have a TMJ dysfunction, you have an atlas. Every time you have an atlas, you have a TMJ. Now, the TMJ is hung by what's called the mandibular sling. If my tie is the mandible, then if you look up here, it's held like this. This would be the masseter. This would be the internal pterygoid. And it's suspended in that by the mandibular sling. Those are both TMJ closing muscles. Now, we swallow twice a minute, 24 hours a day, whether we're awake or asleep. When you deal with the TMJ, you're either going to have a closing problem, basically, or an opening problem, basically. The closing muscles are the masseter, the strongest muscle in the body per square inch, the internal pterygoid, that forms a mandibular sling, and the 3 divisions of the temporalis, anterior, middle, and posterior. Muscles move bones. Those are the closing muscles. So the closing muscles are 1, the masseter, 2, the internal pterygoid, 2 form the mandibular sling, and 3, the temporalis. Okay? Now, a good muscle to screen the TMJ with is the upper trapezius. It's a screen, and only a screen. So you can test the upper trapezius, both sides, should be intact. If it's intact, have the patient bite and retest, and then open wide and retest with the mouth wide open. The patient should be able to open the mouth 3 knuckles of the non-dominant hand. Sometimes I get my foot in there, but this morning I have a hard trouble to get 3 knuckles. Try that. So I'm a lefty, so I'm doing it with my right hand. If you're a righty, do it with your left hand. It's the non-dominant hand. Take 3 knuckles. You can almost do it, but not quite. Okay, you should, that's normal jaw opening. 3 knuckles of the non-dominant hand. Now, the major opening muscle is the external pterygoid. Okay? The major jaw opening muscle is the external pterygoid. That's the major one that opens the jaw. We're going to keep it very simple for right now. So you can have basically 2 types of problems, an opening problem or a closing problem. And how far should you be able to open your mouth? 3 knuckles of the non-dominant hand. Why am I teaching you TMJ in session 3 when officially we don't cover it until session 4? Session 6. Because it's so important. That's the way I teach. I tend to teach you and focus on the important things. And I'll mention the other things. But I want you to be able to find and fix. This class is a practical class. How to find it and how to fix it. And I'll show you how to fix it. Okay? Now, when you check the TMJ, you're going to check it two ways, basically. You're going to check it without therapy localization and with therapy localization. Number one, check it without therapy localization. This is without TL to the jaw. You're going to have the patient bite down or close. If they weaken, it's a tooth problem. And we're going to have them open without TL. If they weaken, it's a fascial flush problem to the closing muscles. So, we're not using therapy localization yet. We're going to take a strong indicator muscle. We're going to have them bite down and then check our strong indicator muscle. If they weaken, it's a tooth problem. A tooth is a gomphosis. And that's not important, but what is important is it is stimulating the periodontal ligament. And what should happen when you bite down, all teeth should come in contact at once. And by stimulating the periodontal ligament, it turns off the closing muscles of the TMJ. That's important. Now, a tooth will therapy localize. The best place is at the tooth gum line. And guess what? The teeth mimic the TS line. So down here, the third molar, that's the sos. Second molar is the quad. The first molar is the sartorius gracilis. The second premolar is the pec major sternal. So your teeth mimic the TS line. They follow the TS line. So each tooth is related to a muscle. Each tooth is related to a vertebrae. Each tooth is related to an organ. Each tooth is related to a meridian. Now, the nice thing about this is you can screen like 3 teeth at a time, so have the patient therapy localized inside the mouth at the tooth gum line, and just go right around 3 teeth at a time. When you find like 3 or 4, then go 1 tooth at a time. When you find the tooth, does that tell you how to correct the tooth? No. Then we use what? Our challenge mechanism to tell us how to correct it. And usually you're going to either do it one of 2 ways. You're going to challenge it towards the tongue lingually or towards the cheek buccally. So you're going to challenge the tooth towards the tongue or away from the tongue. Find the challenge direction. Find the phase of respiration that negates the challenge. Go in the challenge direction on the phase of respiration that negates the challenge. What does that sound like? It's a respiratory adjustment. So I don't recommend you use a high velocity adjustment for the teeth, depending on the situation. But not with the patient anyway. Okay? So we're going to challenge the tooth lingually or buccally. Find the challenge direction. Go in the challenge direction on the phase of respiration that negates the challenge. And you do that usually 4 to 5 times. Just like what? Just like a spinal respiratory adjustment you learned in session 1. And when would you go to the teeth? If it weakens a strong indicator muscle by biting down without therapy localization to the jaw. So you go to the teeth. We call that a neurologic tooth. The nutrition is zinc. Secondarily is bios, or biodent from standard process. Let me keep it simple for now, and we'll build from there. Since you were the smeller, you're the feller. Come on up here, let's demonstrate this. It's okay. Have a seat. Now let me say this. I'm going to demonstrate things in the seated position today. That's just for demonstration. But remember, what did I say about the ileocecal valve? You need to check it how? In all positions. With the TMJ, it's equally as important, at least it's equally as important, to please check the TMJ in all positions. Seated, supine prone, right ear down, left ear down, standing in a gate position. And sit up tall, and bring this knee up. I'm going to push down, you push up. Okay, so that's a good strong indicator muscle. That's a seated rectus femoris. And bring that up, and bite down. Okay, so he weakens on biting without TL. That's a what? That's a tooth. Okay, but which tooth? You've got upper and lower, right and left side, 3 molars, 2 premolars. I'm talking about just on one side now. One canine and 2 incisors. Okay, your teeth are designed to be an omnivore. Cutting and tearing, grinding and crushing. Now, give me one finger. We're just going to start on the left lower, and I want you to go at the tooth gum line in the back, and we're just going to therapy, localize, and test. Okay? Now just work your way right around. You do like 3-4 teeth at once. Okay, so we've got something here. Now what do? Go 1 tooth at a time. Right at the tooth gum line. So there it is. Let me see, which tooth is it? Okay, it's his first, it's his first premolar on the left lower. Okay, I don't use the numbering system because depending upon which dental school you went to, they can use different numbering systems. But when you say molars, premolars, canine and incisors, upper, lower, right or left, then everyone knows what we're talking about. Now, what do I have to do? Right, I've got a challenge to find out how to take the tooth, either lingually or buccally. Okay. Push. Okay, take a big breath in, hold it. Okay, so how do I correct it? In the challenge direction, on the phase of respiration that negated the challenge, I challenged it buccally, and it negated the weakness by having him hold a breath in. So I corrected buccally on inspiration 4 to 5 times. So, I mean, it's really that simple. What's the nutrition? Zinc and secondarily biodent and or bios. Now, remember I said the teeth represent the TS line? Now, lay on your back. There's a little trick here. You may want to write this down. The hamstrings could be the first or second premolar on the lower teeth. The pec major clavicular could be first or second premolar on the upper teeth. Let's have a chocolate thing. Yeah. Guess what? hamstrings could be first or second premolar on the lower, and the pec major clavicular could be the first or second premolar on the upper. Okay? That's just the best little trick when you're relating the teeth to the TS line. Now, if we look at the TS line, and it's his lower first or premolar, that could either be what? Quadratus lumborum or hamstrings, right? So let's test this quadratus lumborum. I know you don't know that yet, it doesn't matter. It's not quadratus lumborum, or it could be what? Hamstrings. Hold this back to here. No, bring this down. Hold this way. There it is. Oh, you need to hang on to the table because you're pretty strong. Scoot back a little bit. Don't hold your breath. Bring your foot up. Pull your heel back that way. Okay, so it's the hamstrings, not the quadratus lumborum for him. Now, the hamstrings are on what meridian? Large intestine. And he'll tend to have, right where the meridian crosses a joint. That'll be very tender when you have neurologic tubes. So you simply trace the meridian. We're going to start that in session 5, but just for demonstration. Right there. Wincing and jerking, and like Rudy did, ready to counter-strike, means it hurts. Okay? So I'm going to correct the tooth. Is it okay? Breathe in and out. I'm going in the challenge direction on the phaser respiration that negated the challenge. And it doesn't hurt or anything, it's very gentle. Okay. Now, come on back up. Have a C-turn, face that way. Bring this knee up. So I didn't mess him up, that's still strong. Light down, hard. He doesn't weaken on biting anymore. Lay on your back with your head up there. Bend your knee, hold your toes up, pull this heel back that way. Hang on to the table. Don't hold your breath. That's gone. He says, which means he expected it to hurt, but it didn't. Okay? So this is not a little thing. These are little things in your mouth that are big things, that have a big effect on the entire system. When you have a neurologic tooth, it creates something called an engram, which is a habit pattern of the nervous system. Do you have a question on how to find it or how to fix it? Let me just keep it very simple for now. We're going to build from here. I got to start somewhere. Okay? If a person has braces on, you just fix what you find. You still do the same. Okay, braces often create a neurologic tooth. Okay, but you can still move it within its gomphosis. Okay? So what should happen? All teeth should meet together at one time. If you have a tooth removed, you should have a tooth replaced, and by stimulating the periodontal ligament, it turns off the closing muscles to the TMJ. Bruxing at night is very often due to retrograde. I didn't say all bruxing, but bruxing at night very often is due to retrograde. That's like a 9 out of 10. Okay? That's pretty neat, huh? And get pain out of that shoulder just like that. Yeah. Is it a question on how to find it or how to fix it? No, is it a question on how to, I'm going to keep it right focused on what we're doing. Okay. Now, what's the other part without TL is open. Okay? So we have them bite and test. If they weaken, it's a what? Say it. Tooth. Okay? Then you use your tool of therapy localization, find the tooth, challenge it lingually, buccally, find the phase of respiration that negates the challenge, go in the challenge direction on the phase of respiration that negates the challenge. What's the nutrition? Zinc and or biodent. A little bit bios too, but biodent is the primary. That was designed specifically for that. Patient has loose teeth, biodent. And check them, they'll probably be taking high doses of ascorbic acid. Now, let me show you the next part. The next part, how do you fix it if they open without TL? Fascial flush, you know how to do that from session 1, and it's going to be the closing muscles you'll need to fascially flush. And you use your tool of therapy localization to locate which one, or ones. Okay, so let me get my tooth man up here again. Come on up and how far should you be able to open your mouth? 3 knuckles of the non-dominant hand. Okay, it helps when you say it. It just cements it in your brain somehow. So when you play with me, it works. Bring this knee up. Okay, how long did that last? Lie down. Well, it lasted that long anyway. Now, open wide. That's pretty good. 3 knuckles of your non-dominant hand. See, he has very good range of motion on opening. He had a closing problem, not an opening problem. Okay? Rob, come on up. I want to keep it very, I can get way more complicated. I'm going to keep today very simple to get the basics put in there. Let's learn it one step at a time. How do you eat an elephant? One bite at a time. What happens when you try to swallow the whole thing? You choke. So let's take it one bite at a time, and what did Fletcher tell us to do? Chew our food 100 times. Okay, so we learn by repetition is the analogy I'm trying to make. Now, bring this up here, push up, light down, open wide. Okay, he weakens on opening without TL. So how do we fix it? Fascial flush to the closing muscles. So now what I'll do is I'll have him TL the masseters, right and left, bring it up, open wide. No change. The internal pterygoids, you have the patient take their thumbs, go to the angle of the mandible, and go to the inside. That's where the internal pterygoid attaches. So Rob, take your thumbs only, go to the inside of the internal pterygoid, open wide. No change. If he did, then I would determine the side. It could be one or both. And then you take a glove, finger, or hand, go take an internal approach to the back of the mouth, inside the teeth, and you'll sweep down the internal pterygoid. When we workshop it, if you can't find it, I'll show you. Once you find it once, you know where it is. Okay? Now, the temporalis is actually 3 muscles, posterior, middle, anterior. So we'll take 3 fingers, middle, anterior, posterior, open. So he's got a temporalis problem, either on one or both sides. So I'll take one hand away, open. No change on that one. Open wide. He's got a change on the right. Now I have to determine is it anterior, middle, and or posterior, or it could be all 3. So we'll go one finger, open wide. It's not the anterior. We'll go to the middle fibers, open wide. It's not the middle fibers. We'll go to the posterior fibers, open wide. And it's the posterior fibers on the right temporalis. How do I fix it? Fascial flush towards the heart in line with the fibers. Okay? Why don't you turn a little bit sideways and I can possibly see this. So I'm going to flush towards the heart in direction of the fibers. Okay, come around here. Bring that knee up, light down, open wide, and see the increase in range of motion. Okay, that's it. That's for without therapy localization. There's only one other tool that you're going to learn for all the rest of it. You only use 3 tools for the jaw. Neurologic tooth, fascial flush, and there's one other tool. Okay, let's learn it simple first so we can elaborate later. We'll embellish on it later. Any questions up to this point of how to find it or fix it? Of how to find it or fix it?
Can you show the right thing of the TS line, how you can get what molar or
Yeah, the third molar is the what? Psoas. Second molar, it's just you just follow the TS line, except that the hamstrings could be the first or second premolar on the lower, and the pec major clavicular could be the first or second premolar on the upper. Right, that's why the hamstrings could be the first or second premolar, and the pec major clavicular could be the first or second premolar on the upper. There's no 2 teeth for the psoas, there's 1. The third molar is the psoas. And it's in your textbook too. You can just follow right around on the TS line except for the hamstrings and the pec major clavicular. Central incisor is sinuses, lateral incisor is the subscap. You just follow right around the TS line. Okay. Any questions on how to find it or fix it? Okay, are you ready for the part with the TL? You sure?
Yep.
You sure?
Yep.
All right. I hear a yes. Okay, how many are ready for the next part with TL? Raise your hand. How many aren't? Sorry. Okay. So the next part is with therapy localization. And when you therapy localize the jaw the way I recommend it, is you do like a Boy Scout salute. So you, position, take 3 fingers, you therapy localize right at the jaw. That enhances therapy localization. That's the best way. Now, if they weaken without movement, in other words, if they weaken just with TL to the jaw, it's usually a small intestine involvement. So you check the quadriceps, both eyes open, eyes closed. The official answer for your test is disc pathology. But more often than not, you're going to find a small intestine involvement. Okay. 2, you have them close the mouth or bite down. If closing weakens, you need to turn down the spindle cells to the closing muscles. And if they weaken with TL on opening, you need to turn down the spindle cells to the opening muscles. That's it. That's 80% of the TMJ right there. Rob, come on up. How do you turn down spindle cells? Turn down spindle cells. Right, you go the opposite of turning them up. You go into the belly and approximate, push together. Okay, bring this knee up. What do we check first? Without TL. So we have a mite. What if he weakened? Say it. It helps. It helps me too. Say it. Okay. And what if he weakens with wide opening? Fascial flush to the closing muscles. Okay. Now we've passed these two things. You do that first. Now what do? Then we TL the jaw. So we're going to have him TL right at the jaw. Bring that up, but don't bite down or open. Okay, he doesn't weaken, but what if he did? Small intestine. Check the quadriceps. Eyes open, eyes closed. And how would you fix it? 5 factors of the IVF. Lymphatic, vascular, craniosternal sacral, nerve supply, small intestine meridian, nutrition and emotions. Okay, but what's the answer for your test you're going to take in session 8? Disc pathology is the official answer. Okay, now what do? We have a TL and what? Fight. Fight down. Okay, he doesn't weaken, but what if he did? That's a closing problem. How many problems do you have in the jaw? Basically 2, either closing or opening. Okay, and if he did weaken, which he didn't, what do? Turn down the spindle cells to the closing muscles. So you have the patient therapy localize the closing muscles. Light down. Take your thumbs, go to the internal pterygoids. Light down. Take your 3 fingers, go to the anterior, middle, and posterior division of the temporalis. Light down. Now let's say he did weaken. Then we determine the side by taking one hand away. Light down. Let's say he weakened. Then we take 1 finger, light down. Light down. Let's say the middle weakened. And we go right to the spindle cells. And we approximate, we push together. Okay? That's all there is to it. If it were a masseter, just go to the masseter, turn down the spindle cells. If it were an internal pterygoid, can you get 2 fingers in there to turn down the spindle cells? Not on most people. So you take a gloved finger and you do just like you did with fascial flush. You go inside and you just run your finger over the internal pterygoid. Do the best you can. Okay. Any questions up to this point? Sure. Okay. So let's review from the top. How do you check the jaw? First, without TL. Get a strong indicator, bite down. If he weakens, say it. Thank you. 2. Okay, open wide. If he weakens, fascial flush to the closing muscles. And how do we find which ones need to be fascially flushed? TL. So we would TL the masseters with wide opening. If that re-strengthened them, then we would take 1 hand. If that was the side, then we would fascially flush towards the heart. Okay? Then what? With TL to the jaw, Boy Scout salute. Okay? What if he weakened just with TL and no movement? Small intestine, check. Quadriceps, eyes open, eyes closed, do the 5 factors. But the answer for the test is disc pathology. Say it. Some of you are staring at me like, okay, get with it a little. Okay. What's the next part? TL with biting. So he bites. If he weakens, then we have him TL the closing muscles with biting. Okay, and if he weakens, we then determine the side. If he weakens there, how do we fix it? Approximate the spindle cells to turn them down. They're set too high. We have internal pterygoids, we have masseters, temporalis are the closing muscles. Okay. Didn't talk about it yet. Right. Okay. No, that's all right. No problem at all. I just want to make sure you got it. This is really important. We're going to be doing this from now until session 8 on the last day. So you're going to get it no matter what. Okay? Why? It's important. Really important. Okay? People walk, people bend, people chew and swallow. That's what people do. Walk, bend, chew, and swallow. A few other things. But those are the biggies. Walk, bend, chew, and swallow. Okay? So you only have 3 tools. What are they? Neurologic tooth, fascial flush, spindle cell down. And spindle cell goes with when you TL the jaw. So if you're not using that, it's either fascial flush or tooth. Okay? Now, let's learn the opening, then I'm going to have you workshop it, then we'll close class. When you open, this is really important. If they have an opening problem, the jaw will deviate to the weak external pterygoid side. Which means you must observe them on jaw opening. John, is your buddy here yet? Derek? Have him report in to me next session. Okay, so watch me. Watch me. I open my mouth. Where's the tight external pterygoid? On the right. Where's the weak external pterygoid? It'll be on my left. Where's the tender external pterygoid? The tight one on the right. You got it. If you have that, you already know more than most out there. Okay? So the jaw will always deviate to the weak external pterygoid on wide opening. Now watch this. Okay. Open. Open. Okay. Now, with him it's real obvious. Watch him. I don't know if you can see it from back there. But that way. Yeah, on wide opening it goes to his left. I didn't know if you could see it from out there. So where's the weak one going to be? Where's the tight one going to be? Sorry, Rob. When you put the glove on in the office, tell the patient what you're going to do. Which way did it deviate? Left on wide opening. Not too bad. That's going to be the tight, tender one. I'm not being mean to him. I'm demonstrating something. It's in the name of chiropractic. Okay? Which is a science and an art. Okay? So, did that fit what we saw? Yes. Now, which side do you think will therapy localize on wide opening? That way or that way? The right will therapy localize wide opening because that's the side you have to what? Turn down the spindle cells to. See how it all fits? Give me 3 fingers. Bite down. It's not a closing problem. Open wide. Are you trying? Okay. Take your right hand away. Should that therapy localize? No. The weak side should not therapy localize because that's not the side you have to what? Turn down the spindle cells. Therapy localize the tight and tender side. That's the side you have to turn down the spindle cells to. Okay? If you have that, you got TMJ. There's 80% of it right there. You already know the TMJ. That's 80% of it. Okay, now, how would you turn that down? Can you get in there with 2 fingers? No. You take a gloved little finger, you take a lateral approach now, go up behind the 3rd molar, and you sweep up, over, and around. Up, over, and around. Okay? And if you do it in a strain, counter-strain position, it hurts less. And only do it once or twice, because that's all the chance you're going to get, so do it right. Okay? Now relax. Relax, open. Relax. Strain, counter-strain position. Well, actually, I wanted to show something. Okay, therapy localized. Bring that up. Bite down. Open wide. Okay. Down. Open. Yeah, much better. How does that feel? Yeah, watch his range of motion now. See the difference? Much less. Okay? That's it. Basically, that's about 80% of the TMJ right there. Okay? So let's review from the top. How many tools have you got to correct the TMJ? 3, and they are tooth, say it. Fascial flush, turning down the spindle cells. Okay, good. How far should you be able to open your jaw? 3 knuckles of the non-dominant hand. If they have an opening problem, which way would the jaw deviate towards? The weak external pterygoid side. It's the external pterygoid that's the major jaw opening muscle. Okay, now let's recap. Find this one. I'm demonstrating sitting, but is this the only position we check the jaw in? No, we check it supine, prone, right ear down, left ear down, standing, even in a gait position. Okay? Bring this up, bite down. Let's say he weakens. What is that? Tooth without TL. Then what do you do? Right. TL 3 to 4 teeth at a time. Where? At the tooth gum line. Find the one tooth, then challenge it how? Lingually or buccally. Find the phase of respiration that negates it. We TL the closing muscles on wide opening, and then determine the side. So we would go here and here, like for the masseters. Open wide. He's strong. Take one hand away. He's strong. So we would fascially flush towards the heart. What's the nutrition? What's the nutrition for fascial flush? B12. Same thing. Same as before. What's the next step? What's the next step? With TL. Boy Scout salute. Go to the TMJ. No movement. No biting or opening. Let's say he weakens. What is it? Small intestine. Check. Quadriceps. Eyes open, eyes closed. But the answer for your test on session 8 is this pathology. Next, we bring him up with TL, bite down. He weakens. What's that? How do we fix it? You only got one choice. Spindle cell down to the closing muscles. So we TL the closing muscles, bite down, he weakens, we determine side, bite down, he weakens, so we go to the spindle cells, turn them down. Okay? We then check the temporalis, bite down, he weakens, he doesn't weaken here, but he weakens here. We find which fiber, turn it down. Okay, we then take the thumbs, go to the internal pterygoid, bite down, he weakens. Bite down, he weakens. We take a glove finger, we take an internal approach inside the teeth and sweep over the internal pterygoid. We're going to show you where that is in the workshop. You just have to be shown on yourself once, then you know where it is. The next one is on opening. Which way will the jaw deviate? To the weak side. Where's the side that should TL? The opposite. Where's the tight, tender side? The side that TLs. So open. He weakens. Okay. Doesn't weaken there. Weakens here. That's the tight side. In reference to this side, we go up, over, and around on the outside of the teeth behind the third upper molar. That's 80% of it right there. You got it. What's the nutrition for spindle cells? Ios. What's the nutrition for GTOs? Ios. What's the nutrition for origin insertion? Ios. That's all from session 1. How many here study between sessions? How many here practice between sessions? Those are the ones that are going to make it. Okay? All right, so here's what I want you to do on the workshop. Let's skip the deep tendon reflexes for now, okay, because that's very simple, right? You elicit it, should weaken once, ipsy hamstring, ipsy tricep, L3, C3. If not, check above and below. That's easy. What I want you to do is workshop the TMJ, and I have finger counts for you up here. So take some finger counts, and I'd like you to check each other in the seated position just for simplicity for now, and get the idea of what? The flow of it. I want you to get the flow. So to recap, one more time, we have 3 tools for the jaw therapeutically. Tooth, fascial flush, that's without TL, and with TL is spindle cell down. Okay? So we take a strong indicator, have them bite. If they weaken, it's a tooth. Find the tooth, challenge it lingually, buccally. Then have them open wide without TL. If they weaken, TL the closing muscles to see which ones negate the weakening. And then that particular one or ones you fascially flush towards the heart. Then you have them TL. If they weaken on TL without movement, that's small intestine. Check quadriceps, eyes open, eyes closed. Fix what you find. Then have them TL and bite down. If they weaken on TL with biting, it's a closing problem. You TL the closing muscles on biting, determine the side, and you spindle cell down. Then you have them open. If the jaw deviates on opening, it will be to the weak external pterygoid side. The tight side will be the tender side, which will be the side that TLs on opening. You take a gloved little finger, take a lateral approach, sweep up and over, turn down the spindle cells to the external pterygoid. That's it. That's 80% of the jaw right there. 80%. If you can do that in all the positions, you already know more than most. What's the nutrition for tooth? Zinc and or vitamin. The nutrition for fascial flush? B12. Nutrition for spindle cell? Bios. Got it. Okay, so let's
let's check each other seated, finger constant here. And let's make this a good workshop for about the next 20 minutes. Have one of the TAs show you where the internal pterygoid is and where the external pterygoid is. And you should have adjusted at least one tooth. You should have fascially flushed at least one muscle and spindle cell down one muscle. So hopefully that was accomplished for you. Let's just review from the top again. And you learn mainly by repetition, and you learn by listening on a relative scale of 10, by watching 100, and by doing 1,000. So you really learn something by doing it. Rob, come on, just because we're just going to run through it. Okay, have a seat there. Okay, so the first thing we want to do is just observe on opening, and the mouth should open in the midline, and what happens at the jaw is rotation with translation. Rotation with translation. There are two motions. What's the muscle that opens the jaw? External pterygoid. And what are the three closing muscles? Masseter, internal pterygoid, and they form the what? Mandibular sling. And then we have the three divisions of the temporalis. So we have one opening muscle primarily, which is the external pterygoid, and we have three closing muscles, two of which form the mandibular sling, the masseter and internal pterygoid, and then we have the temporalis, anterior, middle, and posterior fibers. Okay? Now, we check the TMJ two ways, without TL and with TL. Bring the knee up, find a strong indicator, bite down. If he weakens, that's a tooth. We then screen the teeth, find the one, challenge it lingually, buccally, go in the challenge direction on the phase of respiration that negates the challenge. What's the nutrition? Zinc and or Biodan. Okay. Next thing is we have them open wide without TL. If they weaken, that's a fascial flush problem. We then TL the closing muscles to see what negates the weakening, and whatever one negates the weakening, we fascially flush in direction of muscle fibers towards the heart. And what is the nutrient? B12 with that standard fascial flush stuff. Okay? And how far should you be able to open your mouth? 3 knuckles of the non-dominant hand. The next step is we therapy localize the TMJ, and if they weaken without any movement at all, that's the small intestine, but for your test it's disc pathology. We then have them bite down with TL. If they weaken, we go to the closing muscles and have them bite down. If they weaken here, we determine the side. It could be one or both, and we fix it by turning down the spindle cells in the belly of the muscle. So it could be here, it could be any of these three divisions, or it could be internal pterygoid. What's the nutrition for spindle cell? Bios. We then TL on wide opening. If they TL, we determine the side. And the side that TL should be the side to which the jaw deviates away from, which will be the tight side, the tender side. The side it deviates towards is the weak external pterygoid side. And we go take a lateral approach, go up the pterygoid pocket and over, up, in, and over, to try to turn down the spindle cells to the external pterygoid, which is the major jaw opening muscle. Okay? According to Penfeld and Rasmussen, 35 to 40% of all the motor and sensory nerves of the body are related to the TMJ. Gentleson calls the normal resting position the myocentric position of the jaw. EMG activity on relaxed resting position should be silent to the TMJ muscles. Okay. Any questions on the TMJ? That's about 80% of it. This is only session 3. So where do you, yeah,
Turn it down. Open. Sorry, I'm losing my mark. To try and turn down the spindle fibers for the pterygoid. How much pressure?
which pterygoid?
The income.
Okay,
How much pressure do you want?
quite a bit. You have to get in there and just run your finger over the internal pterygoid. Yeah, about like this. Gary?
On neurological tube, on the meridian, if you have more than one joint that crosses the meridian, would you do the north joint?
Doesn't matter. I mean, like, for example, like the kidney meridian, which crosses the knee and the hip. Usually I'm going to check it at the hip. That'll be the tender one. That's mainly just for demonstration, to show the patient, like a doubting Thomas type of thing.
After the treatment of with the TMJ, suppose the patient starts have a clicking stop, and after treatment, the clicking starts to go away.
I'm not going to answer that right now. Wait till session 6 for that. Her question was on clicking jaws. So let's just learn this first. We don't correct clicking jaws, we correct TMJ dysfunction. Sometimes. It depends. Okay? Any questions on this? How to find it or how to fix it? If you have that, that's about 80% of it, seriously. You have only basically 2 types of TMJ problems. Closing or opening, basically. Without TL or with TL. Tooth, fascial flush, spindle cells.
After this, you check the atlas tube.
You check the atlas before this. So if we were doing a sort of a protocol type thing, I would do all that with the deep tendon reflex, then I'd go to the TMJ last, not first. The TMJ most of the time is compensatory to other structural things in the body. The cranials are compensatory to the TMJ. Wait till session 6. But I want you to know what? Can you do that? Okay? Can you do that? Can you find it? Can you fix it? Yeah.
So, is just the wrist flexors not checked for out?
Wrist flexors being weak is on the side of atlas laterality via the primary atlas technique, which you TL the atlas with the patient's thumbs.
So once you've done the spot, then you, or primary out, then you can do then the right thing.
No, I would do TMJ last. I would do it after ocular lock, occiput, atlas, gate, piriformis gate, plus deep tendon reflex, ileocecal valve, retrograde, then I do TMJ.
But the only one of all those that relates to the primary atlas technique, I mean, that relates to the atlas, is primary atlas.
No, atlas relates to everything in the body. You asked a question in a way I couldn't answer it. Okay, any questions on that, of how to find it, how to fix it? It's hard to hold a conversation with a, well, it's hard to hold a a conversation until you know the alphabet well, and then you know how to conjugate sentences, paragraphs, chapters, and then you can get the whole book. But how do you eat an elephant? One bite at a time. If you try to take it all at once, you choke. You do it little by little. There's a method to my madness. Just try it this way. Take it bit by bit, just the way I'm teaching it. And as you'll see, as each session progresses, that we're building a beautiful mosaic with each piece. But do it this way. Do it exactly the way that I'm showing it. And study between each session, practice between each session, you'll do just fine. Okay? You guys are doing great, by the way. The adjustment, if your marriage seems a failure and your wife is always cross and the pleasure of your life don't even up with the loss, it needs an adjustment. If your religion is out of fix, does not bring the joy it should, it's twice as easy to do wrong as to do your neighbor good, you need an adjustment. If your business is on the bum and nothing seems to pay, if expenses more than double your income day by day, it needs an adjustment. If you're not feeling as you should, your digestion is out of whack, with cold and clammy feelings crawling up and down your back, you need an adjustment. Then consult the chiropractor if you would be free from chills, if you'd have health and happiness, quit taking quinine pills. Take adjustments. That's from D.D. Palmer's The Chiropractor's Adjuster, published in 1910. The author of that poem is Dr. Elizabeth Helfrich. Have a Merry Christmas and a Happy New Year. We'll see you in January of 2001.